You're listening to the Pre-Hospital Care podcast on the Medics Academy Network.
Welcome back to the podcast. In this episode, we're going to be speaking about pre-hospital care in care homes with Lance A. Slatton. So in the conversation, we really want to examine the importance and often overlooked aspect of paramedicine, that of caring for elderly patients in care homes. So as the population ages and more paramedics being called to care homes to respond to complex medical emergencies and indeed involved in multiple patient populations with which have got comorbidities and indeed frailty. So these scenarios present unique clinical, ethical and logistical challenges that demand specialized skills and approaches. And what we want to do in this episode is really talk to Lance about these specific challenges in care homes, including the aspects of effective communication with care staff, managing chronic conditions, ethical complexities surrounding end-of-life care, and much more. We're also going to explore best practices and indeed how we can improve pre-hospital experience for both patients and paramedics in these settings. So to do this, I have Lance A. Slatton with us. Lance is the host of the award-winning podcast and indeed YouTube show, All Home Care Matters. He is a senior case manager at Enriched Life Home Care Services in the US. He's also named as the 50 under 50 for 2023 and received a distinction as a top influencer for healthcare and indeed advocacy in 2024. Lance is also a columnist for multiple healthcare and news websites and print. Lance, welcome to the podcast.
Thank you. Thank you. It's good to be here.
It's good to have you. Lance, I wonder if we could just kick off with just maybe as an opener, looking at some of the most common medical emergencies that you see in care homes.
One of the most common is really people that are living in home. They don't have the support or the care. Family is often unaware of how serious the situation may be. And here in the US, when we talk about a care home, we're usually referring to an individual's private home. We do have group homes, we have assisted living facilities, and then of course, nursing homes or rehab facilities, but we usually just refer to it as home care. And often these individuals are confusing their medications, or they're not eating adequately. They're not getting the nutrition, the hydration, the personal care, their medications in a timely manner or an appropriate manner. And once it reaches us and we go in, there's usually been an emergency. Mom hadn't taken her blood pressure meds for 5 days, or dad hasn't ate or drank anything for, over 72 hours, or they got lost, or they had a fall and nobody even knew they fell. Those are usually the most common issues that we find.
So one of the reasons I wanted to speak to you about this is because within the US and within the UK, the population is aging, and actually in a hierarchy of use case, or indeed the just the frequency of calls, I think EMS staff really frequently and more so are starting to find themselves in home care, in these care homes, in nursing homes and maybe lower level care homes. Could I get you to speak to some of the clinical assessments that account for common issues? You touched on a couple of things which are really interesting. This element of polypharmacy, so patients taking multiple drugs, which is challenging, like say, to document and gather, but also frailty and dementia, which also complicates matters a little bit, because you're right, the patient consultation becomes harder to discern if there isn't maybe other staff or indeed relatives there to start to orchestrate or implement some of the information. Could I get you to speak to some of these sort of confounding factors which make the scenario quite challenging?
Really, it goes back to the family's not aware. Talking about EMS, emergency services, I can give you a real life example that just happened recently with our company. A mother who lived alone. She was widowed. She never had gotten her driver's license, and then all of a sudden she started having sundowning, and the family had lived just blocks away from mom. They had no idea what was going on. And some of this I do put on emergency services as well, because mom would 9, 10, 11 o'clock, midnight, it's dark, she's sundowning. She starts having hallucinations that one of her children are having a large party in the other part of the house. And what does she do? She's scared. and she can't get these people out of the house. She calls 911. This had happened 4 to 5 times. And it wasn't until the fourth or the fifth time that the police decided, okay, there might be something going on here. We need to notify the family. Family blocks away, saw mom during the day, once or twice, 3 times a week, had no idea mom was going through this. Meanwhile, the police were not educated, or the EMS was not educated to properly identify when somebody is maybe sundowning or is having cognitive decline or cognitive issues. And they told the family, well, if mom calls us again, we're going to have to take action and step in and start making some decisions. Well, after the first time or second time, why aren't they notifying the family at that point that, hey, something is going on? Why are they letting it get to a fourth or a fifth time of really a false call, if you will? But the mom, she can't control it. It's not her fault. She's dealing with something and she's not even aware of it when it's happening, right? Because when she wakes up in the morning, she doesn't even remember these things had transpired. So now you're bringing in the family, the doctor who, would see her for regular checkups was not aware of it either. So a lot of times our, emergency personnel, they're the point of contact. They're the first person on scene, if you will, and they're having to deal with this, but they're not sharing that information to say, you know what, there might be something else going on here. This woman, this man might need intervention. They might need some sort of, clinical support or family support. And so the family, got terrified for numerous reasons. They're worried the police or EMS might put mom in a psychiatric hold or a 5150 hold or whatever the case may be. That's a mandatory lockup for at least, so many hours until they can make a determination. Can we release this person? So the family stepped in. They hired our services to go in, and mom hasn't had any issues since then. And a lot of that goes back to, she's having interaction and stimulation throughout the day. If she wakes up scared or has an episode, if you will, then the staff can be there to comfort her, console her. And, her doctor was then able to get her on some medication to help her with these issues. But if none of those things had happened and the police didn't finally call the family, she might be put into here it's called, I don't know, in the UK, it's called geriatric psych, and that's not a place anybody wants their loved one to be at, especially when you have the support and the willing participants and the healthcare support as well to help rectify that situation and get that person the care and treatment that they need.
So you speak to something really interesting, actually, Lance, and one of this is around baselines and appreciation of baseline. And I think it's really difficult for EMS staff, I think, because there often is no prior knowledge of baseline. But that's not to say, to your point, there isn't prior knowledge. It's just not it doesn't just sit with the EMS staff. So, like you said, escalating concern or escalating care or indeed escalating the information early, both to the family and indeed to giving the EMS staff an appreciation of deviation from baseline, because they don't know that lasting baseline is super key. And I guess the question on the back end of that, Lance, would be, what other red flags do you foresee, or indeed you interact with quite a lot, that should really start to alert EMS staff to deviation from baseline?
The red flags, deviation from baseline, that's tough, right? Because when I was going to college, I had taken an EMT course, and then I consequently took a paramedic course. Never worked as licensed paramedic or EMT, but I worked in the capacity for my clinical trainings and then in the hospital. And if I meet you on the street because you're in a car accident and the other driver says, he was shaking really bad and, he's got tremors. One of the first things I'm going to try to identify, does this person have Parkinson's? Do they suffer from any type of seizure disorder? Are they dealing with low blood sugar? Those are things that are visual that you can see, but and I know when you look at somebody walking down the street, you don't know if they have a cognitive issue or not. And so trying to find that person's baseline is really difficult, but you can do a mini mental exam, ask some questions and then circle back and say, do you remember the questions I asked you or the answers? But like with this situation, the example I had given, After the second or third time, and this person's convinced there's people in the house having a party and destroying it, and you go in and you walk through the home and you see there's nobody there, there's no sign that anybody was there, the doors were all locked, that to me would be a red flag. Okay. This person is seeing things and believes things that aren't happening and that aren't there. And then I come back again and again for the same reason. Those are my red flags, right? And I'm going to try to get to the bottom of it. And, thankfully, they did act and they did notify family finally. Um, but that's a difficult one because, you know, it's kind of an unseen illness. And I think for us in our industry, that's one of the hardest things for families and even doctors. You can call your mother who might live in another state or another, country or whatever the case may be. She might be able to say, "Yeah, everything's great, honey. I'm doing good. How are the kids?" But that's very superficial. That's on the outside. Get below that superficial question and that superficial conversation in, US winter and summer taxes. Mom, did you remember to mail in the taxes for, the property taxes? Or Mom, did you pay the light bill? Try to ask more detailed questions that's gonna, cause a little more advanced conversation than just your typical, pleasantries of how are you? Everyone's great. Okay, love you. I'll talk to you tomorrow, because a lot of us can put on that front for a little short conversation, but once you get beneath it, get into more specifics, that's when you start seeing things might not be connecting right. Do they think your brother who moved out, 10 years ago is still in college, but he graduated, or, things that might not quite sit right. Or, if you hear something, follow up with it. Don't just let it go and, chalk it up as, oh, that's just, mom, it's just normal aging, memory loss. There might be something more serious going on there.
So, Lance, something we've kind of touched on, and I'd like to get your take on this, just from either perspective, really. But something we just spoke about is the complexity of geriatric care, of elderly care in care homes. Just, multiple medications, maybe multiple comorbidities and pathology. How would you advocate either, and you can slice and dice this question however you want to answer it, but either, I think one of the fundamental things is how that is communicated to the family, because I think complex information with complex medication regimes is super difficult, maybe for retention. So how that, I'd like to get your perspective on how that's communicated to the wider family, because I think often that is either poorly translated or and certainly poorly retained when it starts to become super complex. And the other part of my question would be, how can we simply pass transfer of information, both from care home staff to paramedics or EMTs, and then to the hospital? Because I think there's information degradation and information entropy in both of those handshakes of information. But I think the most important one, and I guess my first one is, how do we convey that to family so that there's retention?
One of the big ones is make your doctors sit down and talk to you. I tell families, excuse me, I tell families all the time, don't be intimidated by the white coat. I don't know if you've ever heard the expression white coat syndrome. Everybody just takes what the doctor says as gospel. Like they are infallible. They're perfect. They don't make mistakes. We are all human, whether we're wearing a white coat or we're wearing a construction jacket. People make mistakes because we're people. But you as the family, yeah, the doctor's concerned about your loved one, but they're not going to be more concerned than you are as the family. So if you have questions, be that squeaky wheel that needs the grease. They say the squeaky wheel gets the grease because you don't want to hear it over and over. You want them to stop, make them stop and talk to you. If you have questions, don't be afraid to speak up. I tell people all the time, doctors are wonderful people. They're not perfect, but they want to help. That's why they're doctors. I hope that's why they're doctors, right? And they're not going to stop and tell you everything you want to know necessarily unless you ask the questions. They don't know what you don't know. They might take for granted when they sit there and they tell you, okay, mom's dealing with X, Y, and Z. We're going to do this. We're going to do that. And they're talking fast, right? If you're not getting it all, say, excuse me, could you repeat that? Or could you explain that? And I will tell you, more times than not, doctors are okay if you ask, do you mind recording this? Or if I record this, so I can share this with my other family members and we can go back to it and listen to it. Because, when you're in that hospital room, you're in that doctor's office room, whatever it is, something changes once you walk in that door, right? It's a very, solemn feeling for a lot of families. You're dealing with an emotional grief, an emotional strain. You're trying to be there and support your mother or your loved one, your husband, your wife, even your child. And you're the point person. And I tell people, ask the questions, take pen and paper and ask if you can record it. Most people's phones will let you record audio and video, and say, I'm not going to record you, but your picture, but can I record your voice just so we have this as a family? So I can let my brother who lives in, another country, my sister who lives in another state, whatever the case may be, also know so I don't get anything wrong when I'm translating it to them. And, if you have questions that you think of afterwards, call the hospital, call the doctor's office and say, my sister, whoever it may be, we need to know this. We're not understanding this, because you only get such a short period of time with the physician. And once they're out of the room, they might be down the hall with another family, and it might not be that day, or it might be hours later before you can speak to them again. And when you don't understand something, don't be afraid to speak up. They don't expect you to understand all of the nuances and the complexities of the healthcare system in the UK or in the United States. And they want to make sure you are informed, because it's also going to make their job easier. Because if you don't get it, and then they go to do something for your loved one, and now you're saying, well, wait, I didn't know you were doing this. And they're going to say, well, no, remember we discussed this, that, and the other, and you didn't know that's what it meant. That could also cause problems down the road. And as far as relaying and transferring information, there's several things we suggest to families. So here in the States, there's digital records, right? A lot of the hospitals, they share records now if you consent to it and approve it. I recommend approving it. It's only for the betterment of the healthcare your loved one's going to receive. But in the home, we have a thing called file of life. I don't know if you guys have something similar to that in the UK. Okay. And put that on the refrigerator. You don't have to pay and get a fancy one. Make your own. Get a magnet, stick it to the back of it, put it on the fridge. That will have your loved one's allergies, their medical history, the medications they're on, and what their healthcare wishes are. Maybe mom or dad or your loved one, maybe they've decided, you know what, if my heart stops, I don't want to go through all they do to try to bring my heart back. It doesn't sound pleasant. I'm 89 years old. I know I've lived a great life. And when it's my time, it's my time. Or maybe they choose to have their heart brought back. Paramedics and EMS, they're going to be the first ones in the home. They need to know what your loved one's advanced directives or, life-sustaining wishes are. Because if you don't have it and your loved one didn't want all of that done and the paramedics don't know it, they're going to do it anyways, because their job is to sustain life, and legally they have a responsibility to do so. So make sure your loved one's wishes are acknowledged and known. And another way you can do that is give a copy to their family doctor, because if your loved one goes in the hospital, they reach out to the family doctor, they can get more information from them. And when they find out they're a DNR, or do not resuscitate, the hospital will know that. Because don't take for granted your loved one will be in a situation where they can share those wishes. They might be unconscious, or they might be going through a delirium, or any number of things, and they might not be able to express it themselves. And then get a power of attorney for their health care. Pick a family member that can advocate and has the authority to act on behalf of the loved one if the loved one cannot act on their own.
Listen, Lance, I think everything you've just mentioned there is super important, actually. And to your point about being intentional and directed at both an advanced decision and indeed an advanced directive for like say CPR or no CPR, but also, like you said, having a care file, or indeed a life file, which is easy access in the kitchen or somewhere clear, that's easy to access if the patient is at home. We are going to do a series on geriatric medicine and geriatric care, because I think
Wonderful.
this is becoming more central, more important. My next question really is equally as important, Lance, and it really would be around communicating with patients with dementia and communicating with patients that might be hard of hearing or excessively frail. And it poses a number of challenges actually to an EMS provider which hasn't got prior rapport. It really is new to the relationship, new to the environment, and trying to orientate as to what the exact problem is. Could I get you to speak to some take-home messages, front of mind messages for some effective communication strategies to this patient group?
Yeah, well, a couple of things. One, a lot of EMS paramedics should carry a nonverbal communication board where, the little emojis we send our friends or our kids send us if they're happy, sad, mad, they can, if they're able to, they can point if they're nonverbal. But another thing is, there's a whole wonderful series on nonverbal communication, especially for people that are hard of hearing or people that are dealing with cognitive issues. Look for the nonverbal cues. If I come to help you and you're nonverbal and I'm going to transfer you and you know, jolt back with your shoulder or, you grab it or wince, maybe you have a bad shoulder. Maybe I need to transfer you in a different manner. Or, maybe we've all seen a patient who looks just unhealthy. You don't even need to do a workup. You don't need to do an assessment. You're like, this person is not doing good. You know, Start looking at cues. EMS, look in the fridge. Is the milk expired? Did they, are there any dirty dishes in the sink or in the dishwasher? Maybe they're severely dehydrated. Maybe, one of the famous ones, right, is do they have a urinary tract infection? People don't realize, now you and I do, but the average person, they don't realize a urinary tract infection, dehydration, they need to have that area cleaned better. That can cause a significant rise in their cognitive, delirium where they're just not themselves, but you get that UTI cleared up with some antibiotics, they're kind of back to their baseline. But paramedics aren't going to know that as soon as they go in the home. Do an assessment of the environment, check the dishes, check the sinks, check the refrigerator. And then, like I said, the nonverbal cue board, those are powerful. Those are very powerful. And if they have a medicine cabinet or their prescription somewhere, go and look at what prescriptions they're taking. That's also a good cue for, emergency medical staff to kind of get at least a glimpse of what this person might be dealing with.
So just speaking to, I fundamentally agree with all that actually, Lance, and I think that's an excellent strategy. And to your point, the environment speaks quite loudly to the level of daily care and also daily functionality. You're right. Is the food in the cupboards? What's the state of the fridge? What's the state of the cleanliness of the house, or indeed the room? Could I get you to speak to how important it is to have a good rapport with care home staff, just to, I guess, build confidence or indeed build rapport quickly, and also just smooth collaboration? Because some of these acute situations can be super stressful. Like
Yeah.
you said, acute dementia, the elderly patient might be fighting with staff. Could I get you to speak to some strategies just to really de-escalate the scene, de-escalate the environment, and just smooth collaboration?
Absolutely. I love this question for many reasons. When families have a loved one that go into a care home or a nursing home, don't go in with a preconceived notion that the staff is terrible, right? Oftentimes the staff are understaffed and they're doing double work because the facility cannot keep staff or they can't hire staff, especially here right now. I don't know about in the UK. Um, the labor market is very critical. I mean, from our grocery stores to our emergency rooms to our banks, hours are reduced or done away with because they cannot hire people to come in and work. So God bless the people that are showing up to work, whether it's your local restaurant or your nursing home or care home. Go in there, try to have a good rapport with them by thanking them for what they're doing, announcing and introducing who you are and who your loved one is. And honestly, my best advice is maybe once a week, take them in a box of donuts or cookies. There's nothing wrong with trying to, sweeten them up a little bit either, but just your presence in the facility, they know you're a family that's involved and you're a family that cares. And that says a lot to them. I mean, I know firsthand, I would say 90% of our staff at our company came to us from working in a nursing home. And the reason they came to us is they're only having to take care of one person at a time in that person's private home. Sometimes it's a husband and a wife, but usually it's one-on-one versus when they were in that facility, they were having to take care of 16 to 20 people at a time. Now, I don't know if it's true or not, but a lady we recently hired, she said they were so short staffed. It was her as a CNA, certified nursing assistant, a registered nurse, and two other aides for the entire midnight staff for a 60-bed facility. Now, do the math. I mean, the aides, the two aides and the CNA, they're the support staff. They're going in, they're bathing, cleaning, grooming, dressing, toileting, all of those 60 beds. The registered nurse is going around to dispense the medication. And then if there's an elevated medical situation, then they bring in the RN. So you have three people taking care of 60 people. I mean, it's unsustainable. And I always tell people the last place you want to be in is in a nursing home unless you have to be because, let's say your grandmother's in there and your grandma just got cleaned up. The aide leaves, goes down the hall to her next room. Well, grandma needs to go to the restroom and she's a transfer assist. She can't get up and go on her own. She's a fall risk too. She puts on her light. How long do you think it will be before they come and answer that light and come back to her room? She has to go to the restroom, and then grandma's going to feel terrible because she may have an accident in her bed they just cleaned and on her gown that they just put on her. And now they have to do it all over again. Talk to the staff, make your presence known, let them know anything I can do to help you guys, call me, that goes a long way, because it's sometimes a very thankless job and it's not a lot of appreciation because they're really the low man on the totem pole in these facilities with with home care, they're the top man on the totem pole. They're the ones identifying things and, bringing in awareness to issues family and like case managers may not be aware of. They do that in nursing homes also. But again, there's a hierarchy, right? The registered nurse, wonderful also, is an important job, but they're calling the shots, right? They're not the ones necessarily getting their hands dirty like the support staff is on a day-to-day basis. And, just show them your gratitude. Be thankful. If you bring something in for mom, bring enough to share with, her staff for that night. It's just a good way to build some good rapport.
Listen, I think that's powerful, Lance, because I think, as you said, leading with gratitude, it allows you to understand because everyone's worked hard. And like you said, it might be 2 a.m., 3 a.m., 4 a.m. when the
Right.
EMS staff are there. But actually, the appreciation that the care home staff might also be extremely hard worked and actually leading with that gratitude is a nice way of, like you said, de-escalating and building rapport quite quickly. And something else I realized about then in the immediacy of a care home or indeed of a patient's room is trying to use names quite quickly because people identify with names, but also um, especially with any hearing loss or kind of a real loss of situation awareness through dementia, just taking hold of a hand. And it's that, like you said, it's the non-verbal communication. It's the reassurance through just holding a hand or just gently letting someone know that you're there to care for them, just to kind of reassure them on almost a kind of aesthetic level of just that loving touch that you're there and because they may or may not understand, like you say, in the throes of a pyrexia or indeed an infection or something more serious like long-standing dementia, and 3 a.m. when they are acutely confused, they may or may not understand the words you're speaking, but hopefully, and it doesn't always work because, like you said, when there's multiple scenarios, but often use of names, that kind of loving touch, maybe the hand, just reassuring them that you're there, but that leading with gratitude in all circumstances. And it's super hard. I'm not saying that's
Right.
easy over time and indeed over repeating night shifts, but I think that is really a nice phrase and term and reference for these difficult situations.
Yeah, absolutely. And I just to add to that too, be patient. and that's probably the hardest, I think, out of all of it, because you're dealing with two things. We take for granted the staff is educated and understands dementia. And sadly, that's not always the case. They don't get it, they don't understand it. But then when you go in, like if I say to you, right, and you're a healthy male, but maybe you broke your leg and you're coming in for rehab for a week or two, and I'm like, you know what, can you turn the radio down or turn the TV down, or you know what, it's time to take your pills. And you're like, okay, and you take them. You go into a confused elderly person in the thralls of dementia, they might not open their mouth to take the pills and they might, push back and resist. It's not a quick it's not a quick solution. You got to be patient. You got to show compassion, and you're on their timeline. They're not on yours, and it's never going to change. So just being aware of what it is you're dealing with and how, I like to say you've seen one person with dementia, you've really only seen one person, because as we know, it affects everybody so dramatically different, but they still are dealing with dementia, and you just got to be patient, and eventually you can get them to work with you, and but you got to, they're reading your face. If you look angry or upset, or you look rushed, or like you're losing patience, they can see that, and I firmly believe they can understand that's what you're dealing, what you're doing. So just go in patient, take a deep breath, because it might take you several minutes, if not longer. Where if I come into your room and I say it's time to take your pills, you're going to just take them immediately. And I can go on because I have a whole list of things I have to get accomplished. I don't have time to sit here and try to get you to do what I need you to do. But with a person with dementia, you're going to have to do it that way.
So, Lance, something you touched on earlier, which I think is extremely important and relevant and extremely difficult in acute care situations where there is a precipitating cardiac arrest, so a pericardiac arrest situation, or indeed cardiac arrest situation where there really hasn't been an advanced life or an advanced decision on CPR, but there is like I said, multiple comorbidities. The patient might be cachectic and malnourished. There's a real semblance of there's some challenging situations. Could I get you to speak to it's these situations are super difficult actually, and but how you translate information to the family. Like you said, there can be sometimes it's really apparent that there's been a lot of discussion and that there's been this advanced decision made. Other times that you're right, there's been a real deferral of decisions and a deferral of difficult decisions till the point where there is this critical situation in a care home or indeed care at home. And how would you advocate bringing the family along in those decisions, those ethical decisions? Do we continue resuscitation? Do we take the patient to hospital? Do we stop on scene? Which might be preferable if there's if the patient's super old and multiple comorbidities, frail, and there is no quality of life attached to resuscitation, especially advanced resuscitation. Could you give us some tidbits about how to bring the family into those situations so you can have a family informed discussion and really, because often it has to be away from the patient, away from the immediacy of the resuscitation. I've certainly, as a critical care paramedic, had to have some super difficult conversations in the moment where you think, gosh, this should really been had before now. We should have had an informed decision before now, but for some reason it hasn't happened. Could I get you to speak to some pearls of wisdom or thoughts from you as to how to bring families along in these decisions so that they feel informed and empowered?
Well, first, I would hope that the doctor, the diagnosing doctor, when they're getting these comorbidities, has that conversation early on before it gets to that point, so the family isn't hearing it for the first time from a non-doctor person. Um, but like when we do an intake or an assessment with a family, we ask them, do you have advanced directives? Is there a living will? Is there a healthcare power of attorney? And more times than not, unfortunately, they say no. So we kind of educate them and say, in the event that their heart stops in the home, our staff are all CPR certified. We will call 911, but we will be doing CPR because we have to. That's the legal law and expectation. If you don't want that to be done, though, you need to get paperwork drawn up immediately. And, you know, if they ask, well, what would be wrong with doing that? And then we explain, you know, well, chest compressions, you know, your grandma's 89 pounds and, you know, she has end stage cancer. There's a lot going on there. Her lung could get punctured and it could hurt her very badly. And if she is resuscitated, she may end up on a ventilator indefinitely or for a very long period of time. Did she ever express what she would like when that day came? Maybe she lost her husband to a disease or something years prior. Did she ever say what she thought about how that was handled? You know, we never want to try to influence their decision in a way where they'll come back and say, well, why did you say this or what? We just try to give them the facts and let them kind of do some deductive reasoning. And often we'll even say, you know, maybe it's good to have a conversation with her doctor to see what his opinion is on advanced, you know, life support. It's a very challenging conversation. We try to handle it, you know, very softly, very compassionately, but we don't try to overly influence it either because, you know, I feel like it's a very personal decision for the family. And hopefully, if at all possible, their loved one is still, you know, cognitively able and coherent to be involved in the conversation. In the ideal world, they've already had that conversation before it got to that point, and they have a semblance, at least, if not a legal document, of what their loved one's wishes would have been. I'm a big proponent of, I don't know if you're familiar with the five wishes. Have you heard of them? In your spare time, Google Five Wishes, a wonderful organization. It's a booklet, almost like a mini magazine, but it's very, you know, maybe 12, 16 pages. And it's the five wishes that a loved one would fill out for themselves. And it's legally recognized in 48 out of 50 states here. So you don't even need an attorney. And they will say, this is what I want done. And it's not all about their life sustaining services or care. It's also, if I'm not able to act on my behalf, I want somebody to play my favorite music in my it's just a wonderful tool, but it lets families start that conversation, you know, in a very easy, comfortable way where it's not all, you know, death and dying and, you know, what happens and, you know, we give that out to as many people as we can if they don't have something already written up because it lets them have a very comfortable conversation.
Just going to stop there for a second. My microphone has just died, so 2 seconds. Don't know why that just
No
happened.
worries.
Oh yeah, it's
I can
back
hear
on.
you.
It's back on. It's back on. It's
Is
back.
do you pronounce your name Eon?
It's Owen. Yeah, it's Owen.
Owen,
Yeah,
Owen,
yeah, yeah,
Owen.
yeah, yeah.
Okay.
Yeah, that's
All
fine.
right.
That's fine. It's
I haven't wanted to say it in case I screw, but it's Owen. So
yeah.
I got it.
No, it's all good. It's all
It's
good.
a
All
cool
good.
spelling. I like
Yeah,
how you
it's
spell it.
Irish. Yeah, the Irish just love to put vowels together and make people guess. So it's yeah, no, that's cool. That's cool. Right. Okay. Let's have a look. Don't worry, I'll chop this bit out of the conversation. Okay. Um, and just as an adjoiner to that, Lance, what I would say as well is that often these decisions are never made in, like you said, in singularity. So there's normally a plenary group approach. So especially at 2, 3 a.m. in the morning, with some of these very difficult, challenging ethical decisions, in the UK, there's certainly the opportunity to escalate to an emergency operations center where you can share and escalate to an on-call facility, be it a doctor or senior paramedic or senior manager. And I think that's really important in a lot of these, like you said, super challenging decisions that maybe haven't been made. And also involving the family, if where at all possible, at that time, because they are extremely difficult situations, but extremely important ones. So I think, like you said, having a plenary group discussion, certainly with a team on scene and then an extended team before you take any decisions which may not have occurred in the past, and then early involvement of family as much as possible, I think is preferable. Lance, could I get you to speak to in the current climate and certainly on the back of COVID, I think there has been a real challenge in care homes around risk of infection and infection control. Could I get you to speak to the the risk of communicable diseases such as flu or COVID-19, and indeed what you see from your perspective, and just to frame it for EMS staff and also just some of the maybe the risks around tolerance in elderly patients because they have a lowered immune system and indeed maybe a lowered tolerance to fight off some of these diseases?
Yeah. Well, one of the things, Owen, I know right now here in the States, we're going into fall, and fall is big for the flu here in the States. The weather gets cooler, people are staying inside more. And I know I just heard this from a doctor actually this past week. We have like four super bugs going around. And they're viruses. So people that aren't aware, a virus, you can't take antibiotic for it. It doesn't do anything. And you don't want to take antibiotics for just the sake of taking antibiotics because then your body builds up a resistance to those. But with our staff anyways, we we always wear, exam gloves when we're interacting with the staff. We wear face mask and if it's requested, but during COVID, we always wore face mask. And I feel like a lot of that isolation, we were solving one issue by isolating, but we're causing another one by isolating because now with kids and, elderly people, their immune systems got weakened. There were some kids who, my daughter, for example, she was in kindergarten when our state was shut down. And, they're not interacting with all these other people and getting those germs. They're bad, but they're not always bad because those germs also helps your body build up a resistance. So now you're seeing people get sicker quicker, and where otherwise they may not have. And I think it really created and poses a lot of new challenges because, especially for the elderly, they were shut in, locked in, and their bodies just weren't building up that tolerance. So their bodies are already weaker because of the age and maybe other health issues that they're dealing with. Now they get a bug and it could take them down for weeks, if not longer. It's caused a lot of issues. So, I always tell people with our staff, and this is a rule regardless of COVID or not COVID, but if you have a temperature, if you have a cold, if you're feeling sick, don't go to work. We will have somebody cover your shift because, you're not just standing, in a store stocking shelves. You're dealing with people that might be dealing with severely compromised immune systems from cancer or just being elderly they're compromised to begin with. Practice universal precautions, washing your hands appropriately, wearing gloves when interacting, wearing a face mask. If you are sick, know who for us, we call them a client, not a patient. Know who your client is. Do they have a compromised immune system? Are you at risk of exposing them to your little cold could be pneumonia for them? So, practice, good universal precautions and take appropriate steps.
Finally, as we're coming to Lance, on the conversation, could I just get you to speak to some just take-home messages really for EMS staff about how to better facilitate care and indeed support patients you've mentioned some fantastic elements actually, and what sticks in my mind is, like you say, leading with graciousness or gratitude. And what it does is it allows you or me to step out of my shoes and just understand what other people, other care home staff might be dealing with, which I think that's a fantastic nugget. Could I get you to speak to take-home messages just for EMS staff and paramedics dealing with patients in care homes and how to maybe care for them better?
Oh, that's a big question because, every patient's going to have their own situation that they're dealing with. And, first and foremost, EMS, whether it's paramedic, EMT, they're the front lines of our emergency services for healthcare. I tell people all the time, paramedics are amazing, Owen, because I don't know about in the UK, but a paramedic gets to intubate here. They get to perform ACLS. You can't do that. A nurse cannot do that in the hospital. You're getting to do things that only a physician gets to do in a controlled environment inside the hospital, which, is remarkable. And I don't think most people realize the work and training that, emergency personnel like paramedics go through and what they're capable of doing. Um, assuming it's the same in the UK as it is here, paramedics, you're taught the golden hour rule, right? If somebody's having a stroke, you can administer TPN, get them to the hospital to reverse the symptoms of the stroke and maybe cure it. You know, just knowing what you're doing is so crucial and such a vital branch of the healthcare system, whether it's the UK or the United States. And, they're remarkable, professionals that, they're doing things that just aren't done anywhere else. I mean, if I'm choking and my family doesn't know the Heimlich or doesn't know how to try to extract, whatever is lodged in my airway, you know, I'm hoping someone like you shows up because, my neighbor doesn't know how to do that. And they're not going to be able to transport me in their car and get me to the hospital in time so that I can start breathing again. It's only the paramedics and the emergency services that can do it. And, my biggest wish for all emergency services, whether it's police, fire, or paramedics, understand dementia better. A good friend of mine is writing a book right now. He was a law enforcement officer and now he's a tremendous advocate for Parkinson's. But the same will apply, I hope, someday for dementia. He's writing a big book. It will be an academic book for training law enforcement officers and emergency personnel in identifying and treating people that are dealing with Parkinson's. An uneducated police officer might pull you over because you're swerving and shaking. They might think you're using, drugs. They might think you're using alcohol, but really you have Parkinson's and you're having a medical symptom that you can't control. And the time they detain you and maybe handcuff you, all the stuff that comes involved with suspected drunk driving or, drug-induced driving violation is really Parkinson's. Well, the same could be true for dementia, right? It might be dementia. Now you're terrifying this elderly person with dementia or Parkinson's for no reason because yes, you're trying to protect, public safety. I understand and appreciate that, and they're not doing it intentionally. But if we're better educated on the front lines, like paramedics and police and fire, it's better for the patient. So we need to educate people about these issues because, like you said, same with the US, our baby boomer population, right, after World War II, it's exploded. It's the largest population growth in human history. And a lot of the population is going to be dealing with some type of cognitive issue, whether it's Parkinson's or, dementia of some nature. Our emergency services and staff need to understand what those things are so that they can better do their job and support these individuals.
I absolutely agree with that, Lance. And like you said, I think that cognitive issues and cognitive pathologies are becoming more and more frequent, and actually the interaction with pre-hospital care services, EMS, EMT, paramedic services is becoming more frequent as well because, as you said, the population is aging and it's starting to become a more frequently encountered use case. This just leads me to say thank you, Lance, for the last 45 minutes. It's been fantastic talking to you. I am going to include in the show notes links to all home care matters because I think there's some fantastic nuggets of wisdom there, both on YouTube and within the podcast domain, but also just your online presence. So I'll put that in the show notes. I think it's a fantastic resource for people to dig deeper on. But it just leaves me to say thank you, Lance. Really appreciate your time.
My pleasure, Owen. My pleasure. And we need to get you on All Home Care Matters next.
Indeed.
You're listening to the Pre-Hospital Care podcast on the Medics Academy Network.